waiting right from the beginning. And I'll just briefly introduce you before you move on to your talk. Dr. Anil is a faculty in the Department of Pharmacy Practice at the International Medical University in Malaysia. He has gained extravagant experience in pharmaceutical marketing and academics for 6 and 13 years, respectively. He has authored 26 publications, 3 book chapters, and 11 presentations in various national and international conferences. So we are really eager to know your perspective regarding health economics and outcomes research. And I think you would be the best person to give us an idea on how things are practiced in Malaysia. So over to you, sir.
Yeah, good morning. I'll just speak before Anil starts. Good morning, Anil. Nice to see you.
Namaste, sir.
Very nice to see you. And yeah, I think this is the first time we are coming on virtual meeting, isn't it?
Agree, sir. Agree.
Yeah, we did have several talks in the last couple of years.
Agree.
And yeah, so nice to see you. And I'm sure that once COVID pandemic is diluted, you will be flying to India or visiting India soon. I mean, maybe sometime.
Maybe most probably after the vaccines has been reached
Yeah.
to us, most probably in the next April, I may be reaching back.
So, sir, make it a point to visit us.
Sure, sir. I will try to come to Nite.
Please keep a couple of days spare for Nite, and Uday will be coordinating, and I'll be very eager to meet you and discuss the matters over. Yeah.
Agreed, sir. I will do that.
Over to you. Thank you very much.
Thank you, sir.
Sir, you could begin, sir.
Just a minute. I'm sharing my slides.
Sure, sir.
One second. I'm trying. Just a minute. I'm trying to locate my slides.
Hello, sir. Shilpa here.
I am unable to find my slides on my slide. This one, I'm unable to share my slides. I'm using a MacBook now, so that's the reason.
So you can go on to the Finder and just put in your name.
Finder.
Put in the name of your presentation. Finder at the bottom, sir. Bottom there is a Finder, the first icon.
Sorry, 1 second. Bottom, yeah, where?
So your left, your extreme left at the bottom, there is a key down called the Finder. Bottom left, sir. Bottom left.
Sorry.
Sir, it's a blue icon, sir, with a face. A blue icon with a face at the bottom, along with all your other gadgets.
Reactions is there?
Maybe you could open up, go to the PowerPoint folder, sir, the main PowerPoint, which is at your bottom, and then search for your presentation.
I'm really sorry. I am taking time.
It's okay, sir. No worries.
Sir, do you want me to share from here?
Yeah, that would be better. That would be better, Uday.
Yeah, I'll do that.
But it has a lot of animations.
Yeah, that's okay, sir. I'm sharing the slides from here.
Okay, then I will do it. Okay, that's great. Hi, can you hear me now?
Yes, sir, we can hear you.
Okay, fine. Okay, so today I'm going to speak on the pharmaceutical care, the need of our, specifically I'm talking about the Indian context. Okay, I'm Anil. I'm a PhD from Manipal. So currently I'm working in AMU as Dr. Sophia said. Okay. Next slide, please. Okay, so I don't deal too much on the theory. I'm trying to emphasize the fact that pharmaceutical care, how much it is essential for Indian population. That's what I'm going to say. And for that, I am trying to give you the substantiative, the research outputs which has been available in the domain, the public domain. Okay, so what is pharmaceutical care? Pharmaceutical care is a responsible provision of drug therapy for achieving the definite outcomes that improve a patient's quality of life. So there are two important points which I wanted to specifically I have to say, and because even in the Amarjit and Dr. Rajesh has specifically saying that the responsibility of providing a drug therapy to achieve outcomes that is definite in nature, and most importantly, quality of life. This is where all your the health economics and outcome research is being embedded into this pharmaceutical care definition, as you can broadly if you see, okay? So what is the importance of the pharmaceutical care? The pharmaceutical care, the goal is to improve the patient's related quality of health related quality of life, as well as clinical outcomes, as well as with economic expenditure. Okay, I have a money, I can buy a new therapy, okay, but it may not be available to everybody. So what we are looking on it, we have to look at the quality of the life of the patient has to be improved, specifically related to the NCDs, that is non-communicable diseases, and achieve the clinical outcomes and with less amount of the money. Okay, so I'm going to speak more about these three aspects in next 30 minutes. So, and most importantly, you should never forget each therapy for each patient is totally different from another patient. So you may be saying that he is a twin brother of another person, but so that medication work out for a twin brother A may not work for twin brother B. So you should always keep it in mind in that. Okay. So next is, so outcomes. What are the outcomes we are looking? We are looking on it is ECHO model. Yesterday, Dr. Sandeepan has also spoken about this model, ECHO model. What we are looking is economic outcomes, clinical outcomes, as well as humanistic outcomes. Economic outcomes is really purely related to the money, how much you are spending, and what is the outcome you are getting. Clinical outcomes is just like your glycated hemoglobin values, fasting blood sugar values, or total cholesterol values. Okay, so humanistic outcomes is what is the quality of life you are getting out of it, and how long you are going to live in a perfect healthy state by using that particular intervention. Okay. So the process has been depicted in this. So whenever the patient is receiving a drug, it has to be a pharmaceutical care. So this is my objective. When a patient is receiving any medication, he is supposed to be under pharmaceutical care. So this is the process. I will not deal too much into it because you have already been told in your graduate years. So I will not deal it, but it is a customary for me to explain, put this slide because this is a part and parcel of any pharmaceutical care issues. Okay. So before I start the next slides, I would like to tell few important word terminologies here. That is, we go back. Okay. So here the things are years of life lost due to premature mortality is we call it as a YLL, years lost. And then years lived with disability, we call it as a YLD. And then disability adjusted life years, we call it as a DALY, DALY. That is, it is a combination of YLL and YLD. And the most important parameter I am going to speak more often is quality. So quality adjusted life years is like a year of life lived in perfect health is what one quality. That is 1 year of life with one utility is called quality. So you will be using more of this, especially in the research area. Whenever a new drug is coming, so the manufacturer or the research company will be more speak towards the quality to improve their acceptance level, specifically in the new drug applications. So this is one of the most important parameter you should look into it. So why we are supposed to look in this data? So this is a global burden of diseases data, which is it's in a worldwide. So these are the 10 top world disability adjusted life years where they will be concentrated on it. As you can see here, which have been marked here, that is like ischemic heart disease, stroke, COPD, and diabetes. These are the major non-communicable diseases which are most prevalent in nature. And whereas the infectious conditions like LRTI, diarrhea, and then low back pain. So these are the other parameters, they will be coming into the later. And 11th and 12th is usually HIV and tuberculosis. So these are about the world's projection. It has been done in 2019. Okay, so when it comes to India, the causes of the deaths in 2019, as per the 2019 data, the major are here. So again, you can see here the ischemic heart disease, COPD, stroke, as well as diabetes. These are all the few major NCDs, and apart from that, we have like communicable diseases like LRTI is available. And again, when it comes to the diabetes, because most of all the faculty and even my friend Amarjit was talking about the diabetes education and how much it is more important in the Canadian setup. Similarly, India is also having around 65 million cases in 2016, and disability adjusted life years has been for diabetes is 39.6%. And now it has been gaining. Earlier it was not there. The overweight in the adults has been increased to around 20% of the population has been affected with that. Okay. So, and the most importantly, the life expectancy at the birth has been increased in India. You can see the data here. In 1990, it was the year, if they are born at 1990, the age of the people who are going to die is average at 60 years. But whereas in 2000, when they're born, it will be around 70 years for females and 67 years. And if you projected the data into 2100, that will be 80 and 78 respectively. So you can see that as the year progresses, the people are living longer time. So the people will be having the non-communicable diseases more often in nature, and there will be a lot of drugs has to be consumed, and there will be a lot of polypharmacy. I mean, there is a polypharmacy involved. So when there is, as I said earlier, even if there is one drug is involved, the pharmaceutical care should come in, and the pharmacy should come into the picture. And you can see the polypharmacy is there, multiple medications is there. So lot of this. So now we are not talking anything much more on the pharmaceutical care. Now we are the new terminology has come into the practice, that is called evidence-based pharmaceutical care. Okay, so what it is done, what we are looking on it. So in this evidence-based pharmaceutical care, they have done, because now what I'm talking here from onwards, here I'm all talking about the systematic reviews and meta-analysis. So I'm trying to get a lot of data from the systematic reviews, and I'm presenting here just to make sure that this is the ideal path for you to choose. Okay, so what we are going to understand here from this pharmaceutical kit, according to the data which I am presenting, because of this pharmaceutical care, decreased emergency department visits and hospitalization within 30 days has been decreased. And then and I have another systematic review of 298 studies. That is, they were talking about glycosylated hemoglobin, low density lipid profile, BP targets, adverse drug reaction events has been reduced. Okay. Next, medication knowledge, medication adherence, and quality of life has been improved. Okay. And then when it comes to next is we have geriatric care. Next slide, please. Okay, geriatric care, that is a systematic review. It has been done in 2020. It came just early 3 months to 4 months back. So in the systematic review, they have reviewed 13 articles. It has the population base of 8,000 patients. And then they have identified that in the geriatric care, as I keep on telling, the age is increasing, the more people will go into the geriatric. So the majority of the people will be having drug-related problems. That is 4.16 DRPs is we could able to see. Okay, and drug selection is the most important parameter, around 51%. Dose selection is 11% of the problem out of these DRPs. And then patient-related problems is around 10%. And the most important drugs which has been consumed by this geriatric population is cardiovascular diseases, cardiovascular drugs, nervous system drugs, and as well as elementary and metabolism drugs. So you can assume that where our priority should be, where you should learn more on this. So, and when it comes, these are all about, I am talking about clinical outcomes, okay? Because the clinical as a echo model, C is, that is where it is coming. And now I'm talking about cost effectiveness. So whether it is, and again, according to a 2016 systematic review, here it is. Okay, so there are 21 articles in this systematic review they have reviewed, and it is all purely based on European region. And then they are all chosen this perspective from NHS perspective, National Health Services perspective. And then they said that per error, okay, per error of a medication error has been, go back please, 77 pounds has been calculated, and they are willing to pay 75 pounds per error avoided. So, and then 5 years of qualitative life years gained with the willingness to pay around 20,000 pounds per year gain. So you can see that they were ready to pay to gain the quality adjusted life years. They were paying ready to pay, willingness to pay is 20,000. So it means that they were ready to invest the money to get the benefit out of pharmaceutical care services. Okay. So again, when it comes to the critical care where the ICU is there, they have done a meta-analysis, which I'm presenting the data here. There are 8 studies has been done on this meta-analysis. They are specifically on medication errors. So this significantly reduces preventable adverse drug events as well as prescribing errors. So it is clearly evident that pharmacists and pharmaceutical care is very much helpful even in critical care in ICUs. Okay. And the most important, whenever I say NCDs, the major important things, as you can see, as you can remember, that I said is ischemic heart diseases and cardiovascular, specifically ischemic heart diseases as well as stroke, and then cholesterol is the major culprit. So 26 articles in this meta-analysis has been done, and that 22,000 population. And then here the LDL levels, total cholesterol levels, triglyceride levels are being reduced. And there is an increase of high density lipid protein has been increased. So it means that if you give the pharmaceutical care services to a patient, it will surely improve their clinical outcomes. Okay. Again, the diabetes, yes, the diabetes, there are around 43 studies have been conducted, and then it has been analyzed by meta-analysis data. And then their HP is reduced by around 0.85% of a mean difference compared with the standard treatment guidelines, standard treatment, as well as with the pharmaceutical care services. Along with that, there are sub-parameters, subgroup analysis of fasting blood sugar, systolic blood pressure, diastolic blood pressure, LDL, triglyceride, they're all reduced, and as well as the HDL has been improved. Okay, so this is meta-analysis, what it says. Okay. So, and then again, I'm coming back, now I'm again come back to the money, the economic part. In this systematic review of 2015, they said that they had evaluated 61 articles, and then odds of hospitalization when in the intervention, when you do the pharmaceutical care intervention, the interventions lowered the odds of the hospitalization by the odds ratio is 0.91. So that means that if it is 1 and if it is below 1, it is always favoring towards the intervention. And then hospitalization cost has also been reduced. So you can assume that the cost is also reduced when they have conducted the study, when they specifically concentrated on the money. Okay. So now I have given all the information about the world scenario, and now why pharmaceutical care is in India is needed. That is what I'm going to speak. Okay, so here you can see the out-of-pocket expenditure is is a more major money which has been changed hands during the process of a hospitalization. When you go to a hospital, I'm talking about my personal perspective. If you go to a hospital and if it is any emergency condition, you need to have minimum of 20 to 50,000 rupees in your pocket to get admitted into hospital if you don't have any insurances purpose. So the out-of-pocket expenditure has a major impact, okay, specifically in India. And then as per the data I didn't get the recent data for this, the 39 million people have fell into poverty because of the out-of-pocket expenditure. Okay, next. Okay, so and as I was touching upon the medical insurance, this is 35% of the Indian populations are covered in any form of a social or voluntary health insurance, specifically related to ESI, and now the Ayushman Bharat has come into the existence since few years back. Earlier, it was government insurances like Yashaswini in Karnataka and ESI. And majority of the people, the private insurances companies, now they were playing a very well role, and they were giving a lot of services for the minimum amount of the premium we are paying on it. Okay, and most importantly, the expenditure on drugs is also been increasing. Okay, so what we need. Okay, how do we tackle our situation in India? That is, we need a sustainable, high-quality human resources for a health with variety of skills and who are adequately distributed in all states, particularly in rural areas. Now, even you can see in the paper, in everyday newspaper, the doctors are not willing to go to the village side for their practice side. So, even though the government is offering the huge money to go and serve specifically for postgraduate doctors, they were not willing to go and serve there. Okay, so that has become a lot of issues has been raised in these recent days. So, what we need to do is we have to do as a pharmacist, we have to do provide a pharmaceutical care, and we the pharmacist can play a vital role in healthcare system. Okay. Pharmacist, the drawback with us is earlier days when I did my graduation and post-graduation, okay, I could able to do, but after the undergraduation, we had a very little relationship and communication between the healthcare professionals. But when I do my master's in pharmacy practice, I could able to communicate well with my with the healthcare professionals in the hospital. And then I try to exchange our views and ideas so that the doctors started understand our need, and then they understand our services, and then they had given the respect, and that's how we mutually grow. Okay. And most importantly, and this is, I believe that this is a repetition of what my friend Armanjit has said, the community pharmacists also have a very vital role, can play a very vital role in India. And then communication to the physician so that the pharmacist can adjust the change of the medications as per the need. So it's a gist of what Amarjit said. Okay, and in this aspect, I would like to highlight all the PharmD graduates. You can think of, you just try to come out of the box, and then you can try to open up a OPD, pharmacy, retail pharmacy, and you can start doing whatever you have been studied and learned during your 6 years of your study. You can become an entrepreneur instead of being a job seeker. You become an entrepreneur. You open your pharmacy in a taluka place or in a district place where you can do all these services and you can gain your respect. And then, by the way, in that process, you can also rise up other pharmacist level in your own area. So that is what I am planning to do in another format. Okay. So, and when it comes to actually Dr. Sophia and Dr. C.S. Shastri sir has spoken about what we could do. Okay. What we are doing in Malaysia. Okay. So these are the services we are doing. These are all the services we are doing it in a hospital pharmacy. So in a hospital, we have a pharmacist which has been, the pharmacists have been appointed there. it is per ward. Okay, that is a cardiovascular ward, and then infectious diseases ward, and as well as the general ward, OPD ward, inpatient services ward, and then we have a cytotoxic drug reconstitution pharmacist is there. So, and then we have a pharmacist in a total parental nutrition. The pharmacist will mix the parent total TPN, and then he will deliver to the patient to the bedside. And we have discharge medication counseling in the Malaysian hospital setup. And we also have medication therapy adherence clinic, like heart failure. We have a specific medication therapy adherence clinic, so that patients will come to the MTA clinic, and then the pharmacist will explain how to take a medication and what are the parameters. Okay, so I need not to speak on that. You have already studied, you have a knowledge, but only is thing is you have to do the service in the hospital setup. And then type 2 diabetes, and most importantly, warfarin. In Malaysia, we have a warfarin clinics, and most of all the time, until unless there is an emergency, the pharmacist will look after the warfarin patients. Okay. And then most importantly, end-stage renal failure. Who knows better than Uday? Okay, end-stage renal failures, the patients, so they are also, we will be looking at in Malaysian context. We do a lot of service to the end-stage renal failure here. And as a faculty in Malaysia, we train all the students of a B Pharm in all these aspects. Okay, so this is my presentation. I'm just trying to emphasize that you are in a right path. Please go ahead. Please do with your full conviction, and then you believe that I am doing the service to the mankind. If you believe that, nobody can hold you back. Okay, here I wanted to put an anecdote for me. That is what happened to me when I was counseling in my postgraduate level. I was counseling and I was using my pictograms, and then I'm trying to explain the people. I'm trying to arrange a patient, and I explained how to take these medications when the patient is getting discharged. As part of my PG thesis. One of the old lady, she was really touched upon my services, and she said, none of them has done it before for me. You have been so much helpful. Okay, so what do you want? Do you want money for these services? Then I said, no, I don't want anything. I need your blessing, because she's more than that. I was looking her blessings because she's almost around 70 years plus, and she was telling me thank you with folded hands. I was so blessed. And then I said, I need your blessings. That's enough. Okay, and that same thing has repeated in when I was doing my PhD. And then what I am today is because of the blessings of my patients, because of my patients who I've been dealing with for my PhD work, and as well as my PG work. I tried to help them, and they had given enough amount of the blessings for me. That's all what I am here today. Okay, so get a blessings from the patients, try to help them, then nobody can hold you back. Okay, so this is my talk. Now open to you. You can ask me any questions. And namaste for the opportunity. And then you can reach me at my email ID, pharmacistanil@gmail.com. You can easily remember my email ID. Pharmacist is my profession, Anil is my name, and Gmail is a unique Gmail ID. And then you can reach me at even at LinkedIn as well as in the Facebook. Next.
So thank you so much, sir, for those words of reassurance and encouragement. I think there is a question posted for you in the chat box, sir. The question is, sir, is there any course in pharmaceutical care?
We in Malaysia, we have our own master's program. We have master's program in we call it as Masters of Pharmacy Practice, and then we have 3 different divisions in that MPP. One is the clinical pharmacy side, and another one is our social and administrative pharmacy, and as well as we have one more marketing. So if you are really interested to do it, then we will ask the people to go in clinical pharmacy side. So where they will be going to the hospital setup, and they will be working with the hospital for almost 6 to 8 months, and then they will be producing the case reports, and then we will evaluate them, and then there will be a multiple examination. Along with that, we have other course like pharmacoeconomics as a part of a domain, and then we have few more modules for them. So we do have, but it is not extensively for pharmaceutical care. If you have any doubts on the pharmaceutical care, and if anybody wants to uh, pursue their career in the research, specifically in the pharmaceutical care, you can contact me. I'm available, and then if I can help you out in certain aspects of your research or any other parameter. If you wanted to open a community pharmacy, and if you wanted to excel in that, and if you are little bit worried what to do, what not to do, you can always ask me, and then I will try to help you out in that.
Anil sir, how the practicing of pharmacy is different from India in Malaysia, sir?
Okay. First of all, Malaysia has been targeted. The curriculum, B.Pharm curriculum, is not as oriented to industry. Now it is purely oriented to the clinical and hospital pharmacy. So whatever the pharmacists who are going out, they will be they have to register either in a community pharmacy or in a hospital pharmacy for 1 year. They have to work in that particular place, and then only after that 1 year of training, then only they will be eligible to become a registered pharmacist. Once they got it, they will be just graduates. We don't consider them as the pharmacist. Only after 1 year of the training, then only we will consider them as a pharmacist. That's the number one. Second, when they go to the hospital, they have to work from case reports, starting from case reports, and then they have to discuss with the doctors, they have to discuss with the nursing faculty, they have to discuss with the nutrition fellows, they have to discuss with the physiotherapists. So they have to discuss with all the healthcare professionals, and then they have to write, and they have to put their opinion in the case sheets. Okay, they have to put everything on the case sheets, and then they are considered as a part and parcel of the healthcare profession. Okay, and when it comes to the community pharmacy, the people, when you go there, again, the rules and regulations as compared to the Canada is also applicable here. They don't dispense any antibiotics without the prescriptions. Even my students are there. I know because I get some cough, and then I know that is only a dry cough, or if I have some sputum, I wanted to take some expectorant, then they will, even I go to the pharmacy which is near to me where my student is there, they will not dispense my antibiotics. They will never dispense antibiotics to me, even though they have been trained under me. So you can assume that a common man can go and get an antibiotic. It's out of question. And nowadays we are talking about, I believe this week or another last 15 days, we are talking about antibiotic resistance week, and by the FIP and all. So it is very well documented, and the documentation part is very good in community pharmacy as well as in hospital pharmacy. Whatever they do, they will document it. And as per that, my understanding, whatever you do, you have to write it. Unless you write it written down or it has been documented, it is considered it is not done. You can claim I done, but there's no record, so there's no non-conclusion. They simply say you are not done. That's the total. I could say it's a bird's eye view. I could say this is what difference between Indian context and Malaysian context.
Thank you, sir.
Yes, sir. Thank you so much. You've been very kind and welcoming with your talk, and I think you've taken like a proper lecture right from the basics on pharmaceutical care for all our participants. So it should definitely solidify each of our foundations. Thank you so much, sir, for sparing time. Thank you for being patient with all of us, and we hope to see you soon, sir.
Thank you.
Thank you, sir.
And I would like to say one last line, because it has become just like a reunion for me today. Since Amarjit is my classmate, my undergraduate level, Dr. Rajesh is my mentor in PhD, and then Tara Chand, I know him since long time in Manipal, and then Mukesh is there since a long time with me when we are working in when I was working in for my PhD in Manipal, and then Uday, I know him since almost 10 years plus. So it's nice to see all of you in a virtual platform. I'm really happy for you people.
Thank you, sir. Thank you, sir.